Welcome to episode 3 of the modes of mechanical ventilation. Again, we're talking about the most common modes of ventilation that you will probably see and or hear of. So the next mode we want to talk about is volume control. Now remember, in our previous video, we mentioned that there are 3 controlled modes that we're going to discuss. Volume control, pressure control, and PRVC. So we're talking about volume control now. Now in volume control, as its name would suggest, we're going to have a set tidal volume. And this means that the pressure to deliver that tidal volume is going to be variable. Always remember this. If we control volume, we cannot control pressure. And the way around, if we control pressure, we can't control volume. So above, what you're seeing on this slide is the most common parameters that you're going to set in volume control. Now, there are other parameters that need to be set. There's a lot of different settings depending on which ventilator you're using. Some have more, some have less, but these are the most common settings, the most common settings that you're going to hear when you're doing rounds with physicians. So we're going to try to keep it familiar with the basics. So you're going to have a set tidal volume that's going to go into the patient's lungs. A set respiratory rate, how many times they're going to breathe every single minute. A set PEEP, and remember what we talked about earlier on PEEP, that stands for positive end expiratory pressure. It's how much pressure is going to exist in the circuit during the expiratory phase of ventilation, and it's meant to maintain alveolar recruitment that we got during the inspiratory maneuvers. And then a set FiO2, how much oxygen is the patient going to get? This is just an example of some of the basic settings that you might see on an adult patient. Again, these are just some generic numbers. If we really wanted to get in depth, we could spend a great deal of time talking about initial vent settings and how to manage the settings and all of that. We're just trying to give you some basic understandings. So in this particular sample, the tidal volume is going to be 500 mils. Respiratory rate is 12 breaths per minute. A set PEEP of 5 centimeters of pressure, and they're going to receive 40% oxygen. So every single breath is going to be 500 mils. They're going to get at least 12 breaths every single minute. What are some indications for volume control? Well, primarily if you want a guaranteed minute ventilation. Okay, remember, minute ventilation is tidal volume times a respiratory rate. So in this particular mode, you have a set tidal volume, you have a set rate, which means you are guaranteed a certain minute ventilation or a certain volume of air that will go in and out of the lungs in each passing minute. Can't get that with pressure control because the pressure is going to be controlled and the volumes will be variable. If your tidal volume is variable, then your minute ventilation is variable. So you may want this controlled minute ventilation because you're trying to control a certain blood gas result, or maybe it's based on the patient condition, like possibly maybe a head injury. Okay. Now I know that if you go out in the field, there are physicians who say volume control is the only mode that should ever be used. And there are other physicians who say it should never be used. We are the belief that every single mode was designed for a purpose. And you need to know every single mode. We need to adapt ventilation based on the personal needs of the patient, not on our personal needs. Okay. I know the big thing on the ARDSNet protocol. ARDSNet protocol is all based on volume control. ARDSNet is something that will be addressed in some later videos. That again could take several hours to cover. Something we can't cover in basic modes of ventilation. So again, to emphasize certain things we must remember. Volume is controlled, pressure is limited. How many times have I said that? This means if you have a decreased lung compliance, you're going to have an increased peak inspiratory or peak airway pressure. If you have increased resistance, you're going to have increased peak pressures. And it goes the opposite way around, obviously. If you have increased compliance or a decreased resistance, your peak pressures will decrease as well. Also remember, this is not controlled mechanical ventilation. We talked about this, I believe, in the very first episode. This is not CMV. So if the patient wants to breathe above the set rate, they can. Every additional breath they take is going to be volume controlled. They're going to get the set tidal volume that we set, that we showed in slide number 2. Now remember, that's going to change that minute ventilation. One of the reasons why people wanted volume controls is to have a guaranteed set minute ventilation. Well, I think the thing to remember is if the patient's spontaneously breathing, that minute ventilation may be higher than what we want. So we're guaranteed a certain minute ventilation, or I should say minimal minute ventilation, but not necessarily going to be guaranteed a maximum minute ventilation. Something to think about. So now we'll talk about pressure control, and basically everything we cover is going to be the opposite of what we just talked about with volume control. Because in pressure control, we're going to have a set inspiratory pressure the patient's going to get every single time they breathe in. There's a set respiratory rate, a set amount of PEEP, and a set amount of FiO2. So everything here is the same except for instead of a set volume, we have a set pressure. And once again, some sample settings. So as you can see, again, this is for an adult patient typically. Set respiratory rate of 12, PEEP of 5, FiO2 at 40%. And again, the only variable that was changed, instead of a tidal volume, which I believe was set at 500 before, now we're going to set an inspiratory pressure, 20 centimeters of pressure. So every single breath, the machine's going to deliver 20 centimeters of pressure for the inspiratory volume, or inspiratory pressure. So supposedly the only true indications for pressure control is for better oxygenation and when an airway leak is detected. So better oxygenation is achieved because in pressure control, the way the flow of air is delivered, it usually has a higher mean airway pressure. Higher mean airway pressures always equilibrate to better oxygenation. And when an airway leak is detected, so maybe the endotracheal tube is too small, or it's a cuffless endotracheal tube. If you're trying to use tidal volume ventilation in this situation, it's not going to work because the machine is waiting to see that it has delivered that tidal volume. It's never going to achieve that because the volume is going to continue to escape around that leak. And a pressure, you will achieve that pressure eventually. So pressure is going to be a little bit more adept at handling the ventilation needs of a patient if there is an airway leak detected. Things to remember. Remember, pressure is controlled, so your volume is now variable, which means if you have a decreased lung compliance or an increased resistance, you're going to get a decreased tidal volume, and the other way around. If you have an increased compliance or a decrease in resistance, you're going to get an increase in overall tidal volume. And again, remember, this is not controlled mechanical ventilation, so if the patient wants to breathe above set rate, they can. Each additional breath is going to be controlled. It's going to be controlled by pressure. So every extra breath they take is going to be the same set inspiratory pressure every single time. Our next mode of ventilation is pressure regulated volume control, or PRVC. Now, this is kind of a combination of pressure control and volume control combined. And basically what's going to happen in this mode is the machine is going to adjust the pressures to achieve a certain targeted tidal volume. Sound confusing? It's not really that bad. Wait till we get through this and you'll understand. Now look at these settings. These are the basic settings for PRVC. Looks exactly like volume control because it kind of is. We have a set tidal volume once again, a set respiratory rate, a set amount of PEEP, and a set FiO2. So what's the big difference? Well, think about pressure control ventilation. Typically, when a physician puts a patient in pressure control, they write an order that says something like this: put my patient in pressure control and adjust the pressure to achieve X for a tidal volume. So they want a certain tidal volume achieved, and you need to adjust the pressure accordingly. So we continually go in there and we manipulate that pressure based on changes in the compliance and or resistance of the patient, as we discussed earlier. Okay, so we're constantly making those changes. Now, if we set a certain pressure to get a tidal volume and we walk out of that room, how long is that setting really good for? Compliance changes and resistance changes happen constantly in our lungs. And so that setting you put in may not be very good for very long. So here is the big difference with PRVC. In PRVC, as we said before, you're going to set a certain tidal volume. And what the machine is going to do, the very first breath and only the first breath, the machine will deliver a tidal volume breath, a volume control breath with a set tidal volume that you put in. The machine is going to create a slight inspiratory pause. By giving an inspiratory pause, the machine will be able to calculate a plateau pressure. Now every breath after that first breath is going to be pressure controlled. And the pressure that it's going to use for pressure control ventilation will be the plateau pressure that the machine achieved during that first volume controlled breath. So the first breath is volume controlled. Every breath after is now pressure controlled. Now what does the machine do? How does it adjust things now? So what the machine's going to do is it's going to measure how much tidal volume is coming back from the patient with each and every breath. And the machine's going to do exactly what you and I would do if we could sit at the bedside 24 hours a day, 7 days a week and monitor our patient. As the volumes change, we'll slowly adjust the pressures. The key phrase here is slowly. So it's slowly going to increase or decrease the pressure control, by 2 centimeters of pressure every single breath. So if the tidal volume is too small, it's going to slowly increase the pressure by 2 centimeters of pressure every breath until it gets that set tidal volume. Or if it gets to 5 centimeters below the peak pressure alarm. So if your peak pressure alarm is set too low, then you may never achieve the set tidal volume you want, okay? Also, if the tidal volumes become too large, it'll slowly decrease that pressure. Now, why is this so much better than volume control? Because in volume control, we know the pressures are variable as well, correct? The problem is, if you have a sudden, massive change in your compliance in your patient in volume control, the very next breath that's delivered is going to be a very high peak inspiratory pressure. The pressure will change very rapidly and have large fluctuations. It's these large fluctuations in pressure that also change or make large fluctuations in flow. All of these things actually create damage to the lungs. It creates microscopic tearing or shearing injury to the airways. These are the things that create or cause ARDS to happen. Now in PRVC, they're smaller changes, so you're less apt to cause the same kind of airway damage as you could if you used traditional volume control ventilation. And again, the benefit here is we can get a more guaranteed minute ventilation in PRVC than we can in pressure control. So you can see how we kind of take the best of both worlds from pressure control and volume control and put into one particular mode of ventilation. Now it has its drawbacks, and we could go on and on about that, and later there will be more in-depth videos coming on each particular mode. But for right now, that's all you kind of really need to know. You know, sometimes I just get so excited I can't control myself, and so I just talk ahead of my slides. So the last slide, I already talked about what it says on this slide. And I thought about it. I said, well, you know what? I can erase that recording and start all over. But quite frankly, I'm lazy. I don't want to do that. So you know what? You can read this slide and you know it's something we just talked about. We don't need to go and beat a dead horse and repeat everything again. So there you have it. Out of sheer laziness, we're going to go right to the next slide. And again, some basic settings and what they might look like. Again, in potentially an adult patient. Tidal volume at 500, a set respiratory rate at 12, PEEP of 5, FiO2 40%. Basically the exact same example I gave in volume control ventilation. And again, let us remember this is not controlled mechanical ventilation. So once again, if the patient chooses to breathe above the set respiratory rate, the machine will let it. They will let the patient do this, but it is a controlled breath. They're going to get that same 500 mils every single breath, or the pressure control that is set, whichever. Okay, so it is controlled, but they can breathe above that set rate. Well, we certainly hope you enjoyed this video on modes of ventilation, volume control, pressure control, and PRVC. And as always, we do encourage you to visit our websites, www.$10ceu.ning.com. That's our social media platform that's got blogs and various discussion forums that you can follow. It's free. You don't have to pay to be part of those platforms. It's all free information. But if you want to participate in discussions, yes, you do have to create a member profile. Free to do, free to participate. Our goal is to be the leaders in free information on everything to do with respiratory, mechanical ventilation, nursing, whatever it is that topics we need to know about, okay? We want to lead in that. Now, the other website is www.$10ceu.com. That is the only place where we make cash money. We give all this free information away, but if you want to actually get continuing education units for it, it's $10 for each CEU. So you can go on $10ceu.com, take the class, get a credit. It's all good. Well, we hope that you click on the subscribe button so you can subscribe onto our videos, and we will chat with you all soon.